Well, welcome everyone. This is Jeanne-white, and I'm from Social Connections on Passionate World Talk Radio. Now, I do this all the time with everyone that comes on. I'm doing a caregiver series, and each individual has something very important to discuss or make awareness to for other caregivers that are going through some similar problems. And today I have Christinea Turner on, and she's been here before and had some excellent comment remarks that she had to deal with during her process of going as a caregiver. Now today she's going to be talking about something that really is important, not that anything else isn't, but the medication and how it helps or whatever, how do you distribute it to the individual. But Christinea, I want to thank you for coming on.
Thank you, Jean, for having me.
Yes, thanks. And I know you're going to be talking about medication, so I'm going to let you go.
Okay, thank you. Today I would like to talk about two different things in the medication world. This first one is just to bring awareness, and it's certainly not to alarm people. However, there are two medications that are very common that we may have all used or some people for a long period of time. One of them is a statin drug for cholesterol. And the statin drugs have been found to possibly alter people's memory. It doesn't necessarily mean, from everything that I've been able to read in in JAMA, the Journal of American Medical Association, and even what I've spoken with my doctor, does not necessarily mean that it will stay a problem after you have stopped using a cholesterol statin. So there is hope that if it does cause any memory loss, that it will improve afterwards. I have not read any research myself that leads me to believe otherwise. However, in my own experience with my own use of a statin, I did stop using a statin drug probably a year and a half ago, and when I did, it was because I felt like I was having some memory deficit, and I blamed it onto the statin drug. My doctor agreed that if I felt that strongly about it, that I should, and I did. But another drug that comes to mind is something that I just recently found out about, and it's a very common medication. It's a proton pump inhibitor, and that's the name of the drug because it actually inhibits the release of acids from the glands that are in the stomach lining. The meds that I'm talking about would be like Prilosec, Protonix, Nexium. There was a study that came out in February of 2016 in the Journal of American Medication, and they compared prescriptions that proton pump inhibitors, the intake and the diagnosis of dementia patients among 74,000 adults. So they were trying to see what the correlation was between an adult maybe in their 70s and any correlation to dementia. I don't know what prompted this experiment or research to begin with. I shouldn't call it an experiment. It was just research done. But in that study, it was these drugs, the Nexium, the Protonix, and the Prilosec, were defined as using at least one prescription every 3 months in an 18-month window. And all of the people that were looked at, 74,000, were all dementia-free at the beginning of the study. And they did an 8-year follow-up. This surprises me. They had a 44% increased risk of dementia compared to those that did not use those meds at all. Men were even at a slightly higher risk. Researchers were quick to say that this study only provided statistical information, and it did not necessarily mean you were going to develop dementia. However, it really makes one pause and I just want people to be aware of that. We are given those medications for GERD, gastroesophageal reflux disease, for heartburn, and for peptic ulcers. So if you have one of those diagnoses and require some kind of medication to help keep the acid down, talk with your doctor about that and see if your doctor is familiar with the research and studies that have been done on this. I'm not suggesting that you don't use those, and especially if it's a short term, maybe for peptic ulcers. Maybe within 3 months or 6 months, you'd be finished with that anyway. So it's food for thought, just some information that I happen to also have been using Prilosec, so I'm a little bit concerned because I do have some memory deficit. So anyway, the next thing that I'd like to talk about is the use of antipsychotic and anti-anxiety medication in our dementia population. We don't really have a lot of medication that was produced for a dementia population to treat those symptoms. But we do have an enormous amount of anxiety and all of the issues that go along with it in dementia patients, and they do need something. I'm not sure where to preach this to. I can't really hold all doctors accountable because they're not the ones making the drugs. They have a limited supply of what is available, and lots of times they will use whatever is available, but it's not always a good work. It's not always a good fit. And I suspect that it's because most of our medications were made on the premise that the patient didn't have a deteriorating brain, for one thing. And so we're using meds, anxiety meds, that are for regular people that may have some kind of a neurotransmitter malfunction, but for the most part, it's not the same as a dementia patient or person. So I have concerns about those things, mostly because I've witnessed it. I know that in 2006, the Centers for Medicare and Medicaid Services began an initiative that they were trying to decrease the unnecessary use of antipsychotics in nursing homes and the surveyors of skilled nursing facilities. And you know, you can see why. A person would walk in and see their loved one, you know, slumped over in a chair, sleepy, dopey, hard to wake up, and didn't respond very well. And so they're demanding, why does my person, whoever that might be, need to be drugged up? And, well, again, we didn't have any better medicines then than what we do now to treat all of the symptoms that our loved ones suffer with, whether it's anxiety, whether they're nervous, whether they are agitated, whether they, the list of things just goes on and on. You know, I mean, as far as they might even become delusional, they get agitated, they can become aggressive, they can be assaultive. You know, so there's lots of reasons that we have to find some kind of medication to use, but you can also understand why in 2006 they started to take a better look at this and say, we have a real problem here, and maybe we shouldn't be dispensing medication like this to our people in the nursing facilities. So it did slow down the use, and they do have to document much more thorough and detailed information as to why it would be necessary. And also, I want you to know that there's a criteria called Beers criteria, Beers, and it was first developed by a doctor named Mark Beers and a lot of his colleagues, and this goes back to about 1991. And I think they were trying to transition to the American Geriatric Society, and that has about 6,000 experts in its care for older people. It's a nonprofit group, and they are the ones that, the combination that really wanted to inhibit the use of antipsychotic drugs so that people would still be able to have some kind of life function. Otherwise, they looked like they were all just completely doped up every time somebody walked into the bedroom or the day room or the dining room. And they reviewed medicines or medication classes for most older people to avoid, and it was a very strong suggestion. And so some medications were kind of given a bad rap by Beer's criteria for the use in elderly, and especially when it is used in hospice. And I'll go into that a little bit more. A lot of these things in hospice can be a care partner. A lot of these type of problems, hospice will be a care partner to these skilled nursing facilities, and they will help ensure that the appropriate documentation reflecting the need for those kind of antipsychotic meds are why they're used and what the benefit is. The Beer's criteria sort of really put the kibosh to a lot of medicine except in end-of-life care. But we do have a lot of problems before end-of-life care. My husband was actually delusional multiple times long before he came to the end stage and dying. And it was very difficult to find medication that he would benefit from. Now, he may have been an exception to the rule because my husband also suffered from bipolar his lifelong. And in his case, he was more of a depressive state than he was ever a manic state, although he did have those episodes. And he also used medication faithfully. He was a very intelligent man, very high IQ, very well read, and he understood the necessity, and a lot of people with bipolar don't. Now, that disease itself may have had some impediment upon the way that medications reacted for him when he had dementia. We don't know. We never did get to the bottom of it. So that was a real big stressor for all of us. But we just, in end stage, seems like, or the mid stage, people become in dementia much more agitated, and there is cause for bringing in some kind of either an antipsychotic or a anti-anxiety drug. And most of the anti-anxiety drugs belong to a class called benzodiazepines, and they are meant for anxiety reducing, and that's kind of a hypnotic and a sedative. It can be used for anxiety, for nervousness, panic disorders, sleeplessness, muscle spasms, a variety of things. Excuse me. And most of those would be, the common names under those drugs that you would hear would be Valium, Xanax, Ativan, Restoril, maybe even Klonopin. There are a few others. I don't need to go through each one. That wasn't my point. I just want people to be able to understand that with those anti-anxiety medications, there are problems. I mean, again, these drugs were not developed for a person with dementia, and I know that they process things differently with that disease. So you might still see slurred speech, more sedation than what you would like, and it's a real fine line to determine how much, which is worse, what they're experiencing with their anxiety or possibly agitation through sundowning, or giving them medication, maybe a lesser dose, which is what the Beer's criteria was all about to begin with. Make sure that they weren't being overdosed. But we don't know how everyone will react until they actually use it, and that's also a problem. because if you don't have any other help in the home and you've got, it's just you and your loved one, you don't have anybody else. If they start to, easily fall because they are feeling drowsy from the medication, now you've got other problems. And so it's kind of a multifaceted problem with all medications, it seems like. Pain meds would be the same. But the effectiveness of the anti-anxiety meds, you have to weigh that out, and that has to be an individual. You can't go back and say, oh, my God, the doctor just put, so-and-so on this, and they're just, they're not responding well, and they're not eating well now, and they're just sitting here drooling. Well, that same dose might be perfectly okay in the neighbor next door that has it. And that's the problem with all medicine. We don't know how we're going to. And some respond, and sometimes we respond a little better after we've been on a medicine for a few doses, just till we get acclimated to it. And I know that sometimes caregivers are unwilling to try to go through a few more doses. I don't necessarily blame them. I just know that we have a real problem because we don't have any other specific meds to be able to help those people. Every one of the drugs that I gave, the Valium, the Xanax, the Ativan, Restoril, they're all going to come with some side effects. And when we use them in dementia patients, it might be an enhanced side effect, and there's no way to tell. But we don't have a lot of other options. If somebody is hallucinating and to the point where it's really affecting their life, it's affecting their sleep, it's affecting their interaction with the caregiver, it's affecting whether or not they will eat, you have a real serious problem. And you can't really, you're not doing any justification to your person if you don't medicate. And it's such a fine line, and it's such a hard walk to walk. My husband, for various reasons, these hallucinations or delusions can happen. He had them throughout, but it was worse the last 6 months of his life. And in his case, it was because of a very low hemoglobin. He had a bleeder going on somewhere. He had never wanted to have surgery, so the aneurysm that was coming out of his heart was never surgically repaired. 3 years before his death, he had an aortic dissection, and the entire aorta ripped from where it comes out of the heart and goes all the way down to the groin where it splits off to the 2 main arteries in your legs. He should not have lived. He should not have lived the 2-hour trip in an ambulance to the main hospital that was willing to look at him. And the doctor that met us there said, it would be, if I tried to do surgical repair tonight, it would be like sewing wet tissue paper. And, we have probably less than 1% chance that he's going to survive. And I said, he has never wanted to have surgery. That's why he still has this very large aneurysm on the aortic arch, which was ready to have surgery, size-wise. And I can't make that decision for him. So you need to go into the room, and if he's still awake, you need to discuss that with him. Even though I was already his power of attorney, it was a personal thing with me. I was not going to go back on my husband because he had never, ever wanted to have surgery. And if there was such a slim chance that he would even survive, that he'd ever come off the table, I couldn't validate that. I couldn't see that it was worth it. Anyway, long story short, he did not have the surgery, and we stayed in ICU for a long time, and he was titrated with different blood pressure meds to keep the pressure down so that the rip didn't rip further. And finally, he was eventually discharged, much to every doctor that came through there. Every vascular surgeon that came through was just shocked. They told him he was like the luckiest man of the year. He had just won the lotto, but it was in life, not money. So when he had this hemoglobin problem, we didn't really know if the aorta or this aneurysm was leaking or if it was up higher in the GI tract. but he never wanted to have any further testing, and we sure weren't going to do it at that time. So when we found out how low it was from a regular routine lab work every 3 months, we went to the hospital where they did admit and gave him, because he wanted to have the blood transfusion, they gave him a couple of bags of packed red blood cells. And we stayed for a few days, and we ended up coming home on hospice, and they did not expect him to survive even till morning. He was in real rough shape. But with that low hemoglobin, which carries oxygen everywhere, it did not carry enough oxygen to the brain, and he probably had more like a vascular type problem in the end, in the last 4 or 5 months of his life, because of no oxygen getting to the brain with that low hemoglobin. And he literally hallucinated and was delusional almost all of that time. We tried every medication known to man. We used Haldol. We had hospice. We used Haldol. We used Seroquel. We used Risperdal. We used a Risperdal injection that lasted 2 weeks at a time. We used Ativan. We used Valium. The list goes on and on. We used Haldol. We used things every 4 hours, and that was also in combination with the morphine. And the morphine was to help with the breathing, to make his breathing better. And he did have a lot of arthritic-type problems. So he had a lot of pain issues long before the dementia ever set in. And, that didn't go away either. But we never really found any kind of medication that worked. In fact, two and a half weeks before he passed, we had been up for night after night after night, and my hospice nurse encouraged me to place him in the hospital on respite care for 5 days, and the idea was that I would get sleep. Well, I was so reluctant to do that, but I did, and the hospital couldn't put him in under respite for hospice because he was too agitated and too restless. So he had to go under general inpatient whatever ruling. And I also had to provide staff, a family to go and sit with him, because there weren't enough nurses to watch him, at the wandering and trying to climb walls and trying to climb out windows, and it was just nonstop. It was just torturous for him. And he wasn't, we found nothing that was able to help him. We went through all sorts of different doses. We tried, like I said, we tried many different medications, and really nothing really worked. And the sad part was that he was really suffering. And I feel really guilty about that. I didn't have the power to change him. I know that. But I still feel really, really guilty because you watch it and you sort of allow it. The doctor at one point said, the only thing left that I could do would be to send him to a psychiatric hospital. It would be down near Detroit, which is 2 hours away from me, in hopes that one of my colleagues there might be able to find something to help settle him. And I realized that he probably didn't have a lot of time left, and I said, no, I'm not sending him far away and have to live in a hospital down there with new staff, and that's not going to happen. So we did not. However, we were at a loss as to what to do to help him. And so the doctor agreed that he would allow me to give Ativan injections and keep him in a semi-sedated state for the last of his days, which actually lasted 2 weeks. He in the hospital, he had chewed the IVs to get them out of his arm, and he had ripped them out, and they had replaced them so many times. They said, we just can't do this anymore. We're not going to put any more. They would have had to have him in full restraints, and I wasn't willing to do that. So they would take a Ativan and try to slip it under his tongue, because by then, even in the hospital, he wasn't taking any food or drink except for maybe a straw full of water to help moisten that Ativan under his tongue. So, like I say, we don't have medicines. Now, my husband's case may have been a little extreme, but he's not the only person that's going to be to an extreme. And so what do we do for all of the other people that are going to be like him? And what if they're not quite to that extreme? Do we still allow them to suffer because we don't have medications that are effective? Because some doctors, and I suppose I can understand why, especially living through it, they're not willing to jump all over with a different med and a different med and a different med and a different dose. It's really, really hard. You know, you become a bother, I guess. I don't know that the doctor ever really felt that way, but sometimes I wondered. They were attentive. He had a doctor that was very good for him, and then to him for many, many years. We had a very good rapport. And then the hospice situation, I felt like they were open and receptive, and they were willing, but we just couldn't find medication that worked. And so that's a real issue. And I think we need to be looking at drug companies and saying, you know, you guys got to give us something here. We don't have medicine. We have Namenda, Aricept, the Exelon patch or medication, and I think there's even another one out there, which the name just has left me right now, but I'm talking about meds for dementia or Alzheimer's patients, which would be for some of it for behavior and some of it just for no further decline, or to slow the decline, I guess I should say. Those haven't really proved to be, you know, the cat's butt, so I don't know. I just know we have a real serious problem. I know that people are suffering without the appropriate medication, and unless you've seen your loved one go through some of these delusional states, it's really, really hard to understand what I'm trying to convey. My husband would get up in the middle of the night, and one night he tried to take the fur off of the backs of our dogs. He was pulling their fur out because he thought they had worms coming out of their skin. And he tried to climb out windows because he thought they were doors. I mean, the list of things, it just goes on, and it was literally heart-wrenching, and it was exhausting. I really could not continue. It was to a point where I was not very rational because of sleep deprivation. And my kids came, my adult children, and everyone took turns. Sometimes I'd have a brother and sister, or I might have a son-in-law and a daughter, you know, like that. Off and on, the last few months, because when he'd have a really bad episode of this hallucinations, it might last for a couple of weeks before it kind of settled out again. And so if I hadn't had my children, again, what if you don't have children? What if you only have children that live far away? I mean, mine did. I have a daughter and son-in-law that came. They were living in Vegas at the time. They came, but they couldn't stay. And so, you know, it was a reprieve to their other siblings while they were here, but that's limited. And you can't think, you know, you think, oh, well, this can't last forever, right? Well, it did. And so there are just so many issues with our loved ones and medications. I don't know what the real answer is. I just know that we need to make people aware, and we need them to understand that they are going to come with some side effects, And sometimes you really do have to weigh out that balance and, versus them suffering, or do I give them something that's going to ease their suffering, and yet that they're going to have a downslide to it. They might not eat as well because they're feeling dopey all the time, but there just is no specific medication minus any side effects that's going to be effective. So it is definitely a problem, and it's a problem that we should be discussing with lawmakers for their interaction with drug companies. And I have not really started that, but I sort of have. I did speak to left a couple of messages with senators in my state, and I'm waiting for callbacks yet, a few days now, but it will happen. And that was in regard to caregivers' benefits. I see that some states are now considering giving financial assist up to $5,000 per year tax help assist if you're a stay-at-home caregiver. So I know that it has to start somewhere. I don't expect everything to have a complete resolution the first time that they put any kind of a bill through, but there also has to be discussion amongst those that are policy making and the drug manufacturers, because we have got to have something more done, and I think we have to demand it. Just like we demanded things for treatments and cures for cancer, we have to demand more for our loved ones for dementia. And Jean, I guess, I don't know, I don't want to start rambling, so I'll have you come back in and tell me what you are thinking about this.
Well, I think it's for me, it's actually a complex problem because there's so many facets to it. Mm-hmm. You as a caregiver see what's happening when the medication is distributed to your loved one and how it affects them. But again, you were saying that sometimes this medication may work fine for my family, all right? I'm not going to have any issues, but yet on the other spectrum, someone else is going to use that same medicine and it's not going to react the way you think it is. It's really complex. Right. I really think that again, because it took so long, I'm not going to say so long, but to get the people out in discussing Alzheimer's and doing exactly similar things that had happened with the cancer individuals and how they were very vocal. So it's finally coming to a point where you're having more dialogue now, Christina.
Mm-hmm. I agree with that. I think, it's finally come to its time. And I know that there are many people across the United States that are involved in working diligently. I read things, I see things. More and more people are trying to raise money and awareness. And I guess we just need to continue that line of thinking and that cause, because so many more are going to suffer. Right. I did a little video on one of my group pages the other day, and I was just so emotional. I got thinking about all of the people that are already suffering, lifelong suffering with mental illnesses, and then to have to, at the end of their life, the last few years, get dementia of some kind, whether it be vascular or Alzheimer's. And I know that to be true because I lived it with my husband. He suffered in many ways with bipolar. And like I said, he was a very good patient in the respect that he did take his medication, and he did try to do everything that he could, to make improvements in his life. But that's not always the case. And if you're already suffering and you've already alienated all of your family because of either your behavior when you were, in a bad predicament, or because they don't understand, or because it's a lifelong problem and it's not easily controlled, they don't want to hassle with it. They want their life, and they don't want to be bothered. I mean, there's lots of reasons. But then what? That poor person has experienced an exhausting life, and then they end up with dementia.
Again, I think as far as like, I don't know, I hate to keep saying that there's no easy answer. There is an answer, but we just have to keep digging at it, and we have to keep talking about it. And somehow maybe if I can get some pharmaceutical companies, I'm not sure they'd want to come on and talk. I really don't know, or maybe some doctors.
But it's a thought.
Or having some doctors that are really focusing on dementia care, specifically going for that, and see what they're coming up with and what they're suggesting, because I'm sure that some doctors, their hands are tied as far as they've exhausted everything. And, yes, they probably do get, like, I can't do any more for him or her, and they get frustrated, so we all get frustrated.
I'm certain of that. Of that.
Yeah, and
we
then for you,
went through multiple medications with my husband, and I know, and I didn't get, the doctor, even the hospice doctor, didn't really like give me a standoff and say, oh, we can't, there's nothing more. I mean, we did try. We tried multiple. Although at one point I had asked if we would be able to try different medication out of the benzo group, and he was reluctant because it wasn't readily used in hospice across the country. I did provide documentation that a couple of states used this particular drug for this terminal restlessness. However, we aren't using it in Michigan. And again, that goes back to things like this Beers criteria, They really kind of rule the roost, and once they have set in place all these and gotten in place all of these restrictions and guidelines, you have to be very, very cautious about using any medication and following those guidelines because, like you said, everybody reacts differently. So even if you're on the lowest dose of something, you got 2-3 people using the same thing, they're all going to have a different reaction and impairment from it. And so I think a lot of doctors are just, nobody wants to dope up all these people in a nursing home and leave them like that. That was never really, but the desire, it may have happened.
It wasn't their intentions for that. Their intentions is to, let's see if we can alleviate this particular problem. So they would, I don't know, maybe increase the dose or lower the dose, but I've seen it in numerous places in nursing homes when my friends were there and my dad was there. Some people look like, they're not there mentally.
Right, exactly.
Their form is there, the body's there, but they're not there. It's and I'm not sure they want, who would want to be in that state, but how do you know? How do you do this? But these are questions that we need to ask, and who are the best people to ask this question to? Yes, you can go to doctors. Yes, you can go to the pharmaceutical. Yes, you can go to your political, arena, right? And they all have to. Do they all truly understand all the complex that's going on with this? This is not an easy deal, easy situation.
No, it's not. It's much more complicated than what most people understand. And, you can talk to your clergy if that's, you can talk with, if you're not necessarily a religious, spiritual person, you can talk with, your best friend. You can get a lot of input, but bottom line is at some point you're going to be that person that makes that decision for your person, and it's really a struggle. And, I'm still struggling.
I'm sure. It took me a long time for myself to struggle with it, but you do, I just all of a sudden had this idea. Now, I don't know if this is a good one or not, but who best knows when they give the medication and what kind of reaction that individual gets? It's a caregiver, right?
Right.
Okay. So if you could get some caregivers to start a journal on the medication, I'm just saying, I'm just throwing an idea out there. And if
I think it's a great idea, so keep on.
If they could keep a journal on to, I gave John X amount, blah, blah, blah. This is a new medication, and date it so you know. And then you say, oh, gosh, something happened. He's not acting right. He's acting strange. So is that a help? I don't know, but who knows best what happens with this medication is you.
Well, I do think that the caregiver should do that for their own person, because they'll need to be discussing it with their doctor. However, I think what happens sometimes is that caregiver sees these negative things and they say, well, I don't want my mom, I don't want my dad, I'm not going to have my husband acting like that. You know, I'm not giving it to him.
Yeah.
Okay, but I'm just saying, you know, you have to really do a lot of soul searching, and you have to be able to understand if you were in that position, if your loved one could go back 20 years and have a discussion with you about and know what was coming or what to expect, what would they want to do? Because by then, this is about doing what they wanted to have done. My husband never wanted to have surgery, and I was not going to backtrack on him in the most critical hour. I knew if he was going to pass away that night or the next day, I wasn't going to put him through a surgery so he could do it in an operating room. If he was going to die, then leave him in this room with myself and my children at his side.
Right.
So giving him all these medications was the same thing. What can I best do? What can I do the very least of to make things the very, very best for him? And it certainly isn't best. I mean, there was nothing good about any of it. It was all ugly. But what can we do? And so those are the things, you have to live with those choices afterwards. And a lot of times I think people make a choice not really based on their loved ones' needs or wants. It's what they can't stand watching. I understand that too, because there's nothing pretty about it. Either way.
No. I'm sure
I get that. I'm not passing judgment. I'm just saying it is really, really difficult.
I'm just trying to think. I've had my own share of it. You know, it was not difficult. You know, but I did. Mm-hmm. I did what I thought was best with my father, and then with my friends, and I had talked to my friends and my father about certain things. So I've not ever felt guilty for any decisions that were made ever. And
that's good.
And because I had an open, you know, it was an open dialogue beforehand. When we realized my father had been diagnosed very early on. So a lot of discussions were done, at least with me and my father, really. So, but what I'm trying to think of is now, because of all the different types of medication, you know, is that perhaps, you know, you have to go back to the one that's doing all the work, everyone that's going on a daily basis. She or he knows what's going on.
Right.
And if they could do like a video or even on a phone, like do a 5-second, just say something about it, and then see if we could compile it and see around the world, or at least in the United States, if some of it is very similar to other people. Was it good or was it bad? But it has to start somewhere, because doctors, you're saying, if you go into a doctor and you say, I'm not giving him this anymore, because X, Y, and Z. But do they always say that? You know, do they always are open about talking about how the medication affects the individual? Like I know, like Betsy Wurzel does. You know, she monitors what's happening. So if we monitored, I'm not saying me. You know, I'm just saying in general. If you monitored what was happening on a daily basis, is it time consuming a little bit? Probably.
Yeah.
You know.
Yeah.
But in order to
everything's going to be.
Yeah, it's going to take work from everyone, you know. Or even if they just jotted us a line, you know, you or me, and said, this is what happened, we could keep a track. I'm not saying that this is the cure-all for everything, but it's a start. I mean, like if you went to a pharmaceutical company, what are they going to do? I mean, how are they going to figure out what is going to work, you know, because
I really do believe that might be the place to start. Is if anyone, you know, could gather enough pieces of documented.
Yeah.
That's where it needs to go, because those are the people making the drugs for us.
Right.
I know they want to make money, but we need medicines that.
Well, I think some of them
effective.
maybe, yes. I'm not going to say everyone. I think, there are these individuals with brilliant brains, that are developing. And at the moment when they're developing, I'm not sure they're thinking, at least the scientists I'm talking about, maybe I'm being a little Pollyanna here, but I'm hoping that their first thought was, how can I help someone?
I believe that most scientific people really do go in with the idea of wanting to help.
Yeah,
I don't disagree with that at all.
Yeah. So what do you think? I mean, and then bring this stuff to someone and say, look, I have this information, and this find that like 2,000 reacted to this particular drug in this similar way, right? I know it's a lot of work because that would be a spreadsheet, but and then 2,500 reacted this way. And maybe,
I'm not disagreeing with the idea. I like the idea. I think that it needs to be in the planning stages for a little bit because I don't know who or how many would be willing, but I appreciate that train of thought, and I think that it has a good possibility. So I'm going to continue to think about it, and I'm going to talk to some other people about it, and I may even talk with my own family doctor about my own primary care. And
or maybe be able to do some sort of a summit on a webinar. With some different physicians and scientists and drug companies, and then have a group of caregivers be part of it, and be able to talk to them about what is happening when this particular medication is given. It has to start.
We have to start somewhere. I know that doctors have heard these concerns from caregivers. I'm not the only one. I mean, I know that. And I know that everybody has had some probably negative reaction to some of the medication for their loved ones. And I know that they're not all in the last few months or especially the last few weeks, they are not all as severe as what my husband was. I know that. But what about the ones that are?
Yeah, those are the ones you want. That's the ones. They're the ones.
Yeah.
So
we don't want people to suffer.
No, that's not the idea. I mean, you really want to be able to have people to have some sort of peace of mind or have a point in their life when it's not brutal and always in constant pain or constant hallucination, whatever, And
that's very true. My husband's quality of life in general was not going to change. There was no improvement there, but it was. I didn't want him to suffer the brutalness of it, and it.
Yeah.
It gives you nightmares. That's how bad it was for him. And
I'm sure. I can't walk in his shoes. I can only surmise. What may have happened, but I think if we put out a call to some of the physicians and people talk to these physicians about this conversation you are having right now, and say what is it we can do to make medication much more helpful in this process. This my husband or my wife or my grandmother is going through.
Right.
And it has to stop.
I think this is a good talk starter right here, Jean, and I appreciate the idea. And I'll toss it around over the next week or two with some other people, and we'll go from there.
Yeah, and then I'll do whatever I can. I'll help.
I know you will. And I love you for it.
I'll help, but only because, but that's where it starts. It started right now with you and I just making a conversation about what could we do. So, okay, we came up with a couple of ideas. Well, someone else may have a little better idea,
That's right.
Oh, you know what you could do? You could go on Kick-Ass Alzheimer's Movement and talk about this.
and talk about this in particular. I think that's
and just
idea.
Generalize, just focus on this and say, I was on the show, we started talking, and this idea came up and this idea. Do you have anything better? Or maybe there's a physician that may be watching. You have no idea who's watching these videos,
Well,
I think it's a good
if
idea.
I post to that, it's a closed group, so really only the people that are in the group would be seeing those.
Well,
now,
I
don't have any
you can
objection
do
to posting one on my page and putting it public.
You can post it on my page. You can do it on my page.
Okay.
All right? And
All
then
right,
I'll have a lot of friends push it all around.
Okay. Well,
All
give me
right?
a few days to gather my thoughts.
Oh, no, I don't want you to do it. Oh, God, no. It's going to take it has to take a planning. You have to have a whiteboard and say, this is what I'm going to do. And it would take it probably a few weeks or maybe a week or so to gather, or 2 weeks to gather your thoughts and everything and how you want to approach it, So it wouldn't
expand, but, you need it to be as brief and getting the message out to begin with as possible. So
you can just say, look, I was on an interview and we were talking about ideas, and I'm reaching out to this audience to see, do you have any ideas and thoughts how we could proceed with understanding the process of the medication and how it reacts to different individuals and how we can perhaps talk to a drug company. I don't know, but I'm just saying that that's how things happen by an idea. That's all it is.
One little spark, and everybody benefits from knowledge. So everybody adding
this idea
to it.
Yeah, I'm sorry. I overtalked you. I'm sorry. I apologize. Yeah. But the idea could expand even better. Someone else could come along and say, well, the idea is great, but if we did it this way, and that gets people becoming creative and thinking about how to solve a problem. And this is what this is: how to solve this problem. It's complex, but if we break it down into puzzle pieces, it works. Rather than looking at
caregivers. You're right, a puzzle piece. And I think that caregivers will feel involved, and sometimes that's more important than anything. Addressing the fact, acknowledging their problems, and involving them.
They'll feel empowered.
Mm-hmm.
Because now they say, okay, I can help. I don't have to become I'm not the victim.
Right.
Do you ever feel like that?
Oh, more times than I wanted to.
Oh, of course, with me also, but because I'm doing something else right now, and with another group.
Okay.
And one of the things was, all of a sudden I was sitting there and I went, oh my God, you need to be empowered. See how that word is beautiful, really. Because
yes,
you
it
can
is.
apply. Yeah, because you can apply it everywhere, really. You empower yourself. You empower someone else. And I think...
I'm sorry. I need to interject or I'm going to forget this piece. This is so true of what you just said. In a separate group, not the kick-ass Alzheimer's group, in a separate group, I asked a few days ago, what is the one thing that you have found the most valuable about yourself in your caregiving? And at first I wasn't sure I was going to get very many responses. And then they started to come in, and then they built, and they built. And the strength that they felt, the empowerment that they felt of succeeding at caregiving most of the time was just, it just made my heart swell, really. It was just the most beautiful thing. And so your statement is correct. Empowering is a beautiful thing.
It is.
Mm-hmm.
I mean, because we're using it for something else. I'm doing. I belong to. Well, I'm going to be an officer there, but Stop Health Care Violence, and we're working on a bill for changing some wording, and we now became a nonprofit. And we want to figure out how do we provide a form of self-care, to these nurses and doctors that get hurt. And
sure.
And I just sat there and went. That's when I went, oh my God, we'll do a Facebook page and we'll call it I Am Empowered.
Wonderful.
And we all sort of looked and said, yeah, that works. You see? But you see, everyone had that same thought immediately as soon as I said those words.
Yeah, that's wonderful. Really, it's good to hear.
Yeah, it is. But
good for you. Good luck.
I'm busy.
I bet.
But I like helping causes. I really do. I love it. If there's a way I can do it, I will.
We have such little other ways to help other humans in this world. I don't know about you, but I financially cannot afford to help people in that way. So what's the most important thing that I can do? I can give them my ear, and I can give them my heart, and I can give them my mouth.
Yeah. And those are important.
Yeah.
It's better than finances, I think.
Yeah, it's very rewarding. Mm-hmm.
It is a very both parties, but I think that we're onto something, and I think we should not let it go. And anytime you can come back every week, Christina. Trust me.
Oh, that'd be great. That would be great.
You can come all the time, and maybe we'll do some audio, some videos. All right?
Right. I'm perfectly okay with the videos.
Yeah. So why don't we try the next time? We'll do a Zoom one.
Okay.
And I'll do a video, and and for that I like it to be. I don't like it to go over 30 minutes.
No problem.
All right.
Yep.
And that way we can, you can get a lot out. Even 20 minutes, you can get a lot of stuff out. So if we just give little pieces and everything, and then you build up, and that and people see you, and now they look at you and they say, oh my God, she's a caregiver, and you're going to bring strength to people and information.
Well, that's what we hope.
Thing.
That's what we keep hoping.
Yeah.
So,
definitely.
Okay.
I don't know.
We'll talk again soon then, and I
yes,
really
we will.
Appreciate you so much. I cannot even describe how much. I had no idea that somebody like you was even out there. So, thanks.
Well, let's hope that we can get more hosts. That's what I'm looking for. I'm looking for more hosts to interview gals. Oh, you are.
Yeah, that's great.
So it is in the works. It just takes a little time. It's like anything. It's like you plant a seed, and you nurture it, and it'll come when it's supposed to. But I can't thank you enough for being on. Is there anything else that you want to relay to the audience before we close?
I just want them to know that a lot of people care about them. And I know that you are all having good days, and I know you're all having some bad days. And through these talks, through these interviews, and through our Facebook groups, there are people all across the country that actually genuinely, truly care about you and your loved ones. So remember that. You're not alone.
Well, thank you very much for those words. I'm sure they're wonderful words to tell these individuals, caregivers that are listening to us. I want to thank you again, Christina, for coming on. This is Jeanne-White from Social Connections on Passionate World Talk Radio, and we will have Christina back again. This time we're going to do a Zoom with her. We're going to do a video, so this will be very interesting and really great. So I want to thank everyone for listening to us. Again, this is Jeanne-White from Social Connections on Passionate World Talk Radio. See you next week. Bye now.